Good evening, everybody. It's a pleasure to have everybody on board for this great meeting and for this GIS educational program. Today, we're going to have quite interesting lecture and with some interesting cases. Today's subject is the management of multivessel disease in Stemi patients. We have today a couple of great speakers. We have today Professor Mamas with us, our panelists, Dr. Mohammed Mukhaini and Dr. Abdullah Al-Anizi. Our presenters today also, Dr. Fikri Deeb and Dr. Ahmed Qasim. To start with, we're going to start with our main speaker here, Professor Mamas. He's a professor of cardiology at Kiel University. He is the clinical director of NIHR and MRC funded centers for prognosis research of Kiel University. He is the consultant intervention cardiologist at the Royal Stoke Hospital in the United Kingdom. So I would love everybody to welcome Professor Mamas, and I would leave now him to present the main presentation.
So thank you for your very generous introduction, and it's a real pleasure to see so many delegates here, many people that I consider personal friends from all over the Middle East. So I think it's going to be a very exciting hour and a half with talks and quite a few interesting case discussions. So really over the next 20 minutes or so, my remit is going to be to discuss what we do in non-culprit lesions that we encounter in primary PCI. Now this is a problem. Primary PCI, we often find that around half of patients that we take to the cath lab for Stemi PCI have non-obstructive and non-infarct related coronary artery disease. Around 30% of these patients have single vessel disease, and 20% of these patients have two vessel disease. So why is this important? Well, this is important because the presence of multivessel disease gives a worse outcome in patients undergoing primary PCI. So this is a retrospective analysis of 8 Stemi randomized controlled trials containing 28,000 patients. And you can see that with non-infarct related disease, there's almost a doubling of 30-day mortality compared to patients with culprit lesions alone. Now, these lesions are not benign. This is data from the landmark Prospect trial. So the Prospect trial was a trial whereby patients that were admitted with an acute coronary syndrome had IVUS investigation of all 3 vessels. So IVUS investigations of both the infarct-related vessel, but also the non-infarct-related vessel. And you can see that, that at least as many events were happening in the non-infarct-related vessel as in the infarct-related vessel. And so what's that telling us is that these vessels that aren't causing the infarct are at increased risk of having events further down the line. And if we look at the actual data itself from one of the tables in this paper at 3 years, you can see that in terms of composite cardiac events, as many, so 11% of the events are happening in non-culprit lesions and 12% are happening in the culprit lesion. So what that's telling us is that this extravascular disease that's not the culprit is prognostically significant. At least half of the events happening at 3 years will occur in these sites that are not the culprit lesions. And this pertains to whether it's myocardial infarction, revascularization, and so forth. And so, you know, we should consider these as high-risk lesions. And so the question has been now for many years, what do we do with these lesions? You know, what do we do in a patient that comes in for a primary PCI and you find a further significant lesion elsewhere in the coronary vasculature? Should you treat it? Should you leave it alone? And so we have a number of options. So if you have a patient that comes in with primary PCI, obviously all of us will do primary PCI for the culprit lesion. But then what do we do for the non-culprit lesion? Well, there's a number of different strategies. You could just say, I'm going to treat it medically, and only then undertake PCI if there's angina pectoris. You could say, well, I'm going to undertake FFR guidance or ischemia guided therapy and only treat the lesion if there's ischemia, either with FFR or a non-invasive stress test. And you could either do this as an inpatient or an outpatient, or you could decide to undertake early stage PCI by angiographic criteria, and you can do this as an in-hospital event or a post-discharge event. And really, you know, we have a lot of these options, and a number of trials have been designed over the past few years to inform us which is the best guidance in these sorts of cases. And if you look at guidelines, again, guidelines give very different recommendations. So the European Society of Cardiology guidelines for ST elevation myocardial infarction give a 2A level of evidence A, that we should routinely revascularize non-infarct related lesions in Stemi before hospital discharge. In contrast, the ACC guidelines give a class 2B indication that say that PCI of non-infarct artery may be considered in selected patients with multivessel disease. So far less aggressive approach recommended by the AHA ACC guidelines. And so really, what's the evidence basis that guides this practice? And this has come from a number of landmark trials that we shall briefly explore. So really, one of the first trials was undertaken by one of my friends in the United Kingdom, Tony Gershlik, called the Culprit Trial. And this was a randomized controlled trial of 296 STEMI patients with multivessel disease at 7 centers, randomized either to in-hospital complete revascularization or just the infarct-related artery. And for the complete revascularization arm, it was suggested that the index procedure should occur in hospital. So the primary outcome of this trial was death, recurrent MI, heart failure, and ischemia-driven revascularization. And you can see at the bottom right-hand slide, you can see that the total MACE was significantly better in the complete revascularization arm. So certainly there seems to be a reduction by around 50% of events. But if we look at the individual endpoints, there was a trend for all of them, but none of them were significantly reduced. And that, you know, perhaps relates to the fact that this was a very small study and underpowered. And obviously with very small studies, you always have the issue of type 2 errors. The next study that focused around this question was the Prami Trial, again, a trial from the United Kingdom. And this was slightly larger. So this was 465 patients in 5 centers in the United Kingdom. And again, patients had to have multivessel disease and were randomized either to complete revascularization or infarct-related artery PCI only. And the primary endpoint was cardiac death, non-fatal MI, or refractory angina. And again, in this study, the complete revascularization had to take place during the index procedure. Now, there were many exclusion criteria. So exclusions included things like cardiogenic shock, included left main disease, or CTOs. And the trial was prematurely stopped because of better outcomes in the complete revascularization group. And you can see from the pre-specified outcomes that there was a marked reduction in death from cardiac causes, non-fatal MI, or refractory angina. And the thing that's really driving these differences were the reduction in non-fatal MI in the multivessel PCI arm and the refractory angina. And clearly we see a reduction in repeat revascularization as well. And you can see that the effect occurred relatively early on, but was persistent. So it wasn't something that happened in the first couple of days and then remained constant, but you can see that the Kaplan-Meier curves continued to diverge over time up to the 3-year follow-up period. So you can see that doing multivessel PCI, certainly in the Prami trials, associated with better outcomes in this group of patients. The next group, which I think was quite an interesting study, was the Dynami 3 Primorti study. So let's not forget that up to now, all of the trials have looked at angiographic significance of the non-culprit lesion disease. And we know from studies such as DEFER that up to half of these lesions may not be functionally significant. And we know that certainly from, again, trials like DEFER, that treating such lesions may do more harm than good, particularly at the 3-year outcome data of the DEFER trial. But we also know from, say, FAME2 that revascularizing FFR positive lesions is associated with a reduction in incident AMI in these patients. And so the Dynami 3 Primorti trial looked at whether, you know, the outcomes were improved by using an FFR guided approach. And the patients were 627 STEMI patients with multivessel disease that were randomized either to infarct related artery PCI or FFR guided complete revascularization. And PCI in the FFR guided revascularization, they encouraged for it to be done within the first 2 days. And the primary endpoint was all-cause mortality, non-fatal MI, and ischemia-driven revascularization. Now, the important point of this is that when you FFR non-culprit lesions, around 1/3 of these lesions had an FFR greater than 0.8. And the primary outcome was reduced in the complete revascularization arm. But interestingly, this was not because of hard endpoints such as mortality or AMI, but merely by the reduction in ischemia-driven revascularization. And these are the primary endpoints. And you can see that most of them, as I mentioned, were non-urgent PCI that were driven. So perhaps a slight reduction in urgent PCI, but numerically, the ischemia-driven target lesion revascularization was mainly in non-urgent cases, so elective cases by patients having continued angina post-discharge. But looking at the other events, there was no significant difference in cardiac death or non-fatal MI. So the final one before we get to the complete trial was the Compare Acute trial. And the Compare Acute trial was a slightly different design. So this was, again, STEMI patients with multivessel disease. And they were randomized 1-2 to either FFR-guided complete revascularization arm or infarct-only revascularization, where they did FFR, but were told not to revascularize, just infarct only. And the recruitment was slow, on average, 1 patient per month. And interestingly, again, undertaking FFR in the infarct-related artery revascularization only group, only half of these patients had a functionally significant lesion. So what we can say from this study and the previous study is maybe between 50 and 70% of non-infarct related vessels are functionally significant if you measure FFR. And most of the FFR-guided revascularization either occurred during the index procedure or within 72 hours. And the primary outcome was cardiovascular mortality, non-fatal MI, revascularization and stroke. Now, the important thing to point out is that, you know, we all know as clinicians that undertaking FFR is not without risk. And so in this study, 0.2% serious complications associated with an FFR wire, and these were death and STEMI. So, you know, undertaking FFR is not risk-free. And these are the Kaplan-Meier curves. So you can see better outcomes in the complete revascularization arm. Now, this is interesting because actually there was a significant reduction in MACE, but no significant differences in death or myocardial infarction. Most of the benefit was from revascularization. And you could see a marked improvement in revascularization. But then when we look at the revascularization events, you can see that first and foremost, a lot of the revascularization events were for stable angina. And so you can immediately see that perhaps, there's not such a clinical benefit. All you're doing is just treating patients for stable angina. And, another third of patients had no angina and no ischemia. And so they were being revascularized just on the basis that they've got significant disease, not on the basis that there's ischemia, not on the basis that they've got angina. So actually, only a third of cases were revascularized because of an urgent admission. And actually, when the cases were clinically adjudicated, 20% of the cases were deemed to be clinically not indicated. And so immediately you can see that many of these older trials are driven by revascularization, the endpoints, particularly the larger ones. And many of these revascularizations are for stable angina or not clinically indicated. And so really, this is sort of the background as to why the COMPLETE trial was so important. And I think, the COMPLETE trial is really a landmark trial that guides our evidence, because for once it was a trial that was adequately powered for hard endpoints. And this involved recruitment of over 4,000 Stemi patients with multivessel disease that were randomized either to complete revasc or infarct-related artery revascularization only. And there were two co-primary outcomes: death from cardiovascular causes, or NUMI, and death from cardiovascular causes, NUMI, or ischemia-driven revascularization. And the criteria for multivessel disease, as before, at least 2.5 millimeter diameter, amenable to successful PCI, 70% diameter stenosis by visual estimation, or if the stenosis was smaller, so between 50 and 70, then you had to have positive fractional flow reserve. And there were a number of exclusion criteria, which are the standard exclusion criteria for these sorts of trials. And this was a good study. First and foremost, it used contemporary antiplatelet agents. So again, this is important because the outcomes from stenting are better, but also the longer term outcomes of the non-infarct-related lesions may be better because you're using more potent antiplatelets. So 70% of patients had either ticagrelor or prasugrel. The other thing is that very few left main patients and very few CTO patients. And these are the results. And so you can see for both primary endpoints, a significant improvement, a reduction by around 25% and 50% respectively, associated in the complete revascularization arm. So there's a 25% reduction in death from cardiovascular causes, or NUMI, and a 50% reduction in death from cardiovascular causes, NUMI, or ischemia-driven revascularization. And these are the data, and you can see that there's a number of key factors, and in particular, that this is not a soft endpoint study. The main benefit was driven by a reduction in the hard outcome of myocardial infarction, but also in ischemia-driven revascularization. But there was no significant difference from death from cardiovascular causes or all causes. And again, looking at the subgroup analysis, which I think is really important, whereas the previous trials had all mandated the non-infarct-related artery PCI to occur as an inpatient, let's not forget that the COMPLETE trial allowed individuals to do it up to 42 days post-discharge, and you can see that there was no difference in outcomes stratified by whether the complete revascularization occurred in the in-hospital setting or post-discharge. And so the COMPLETE trial really allows us to decide whether we do this all as an inpatient or as an outpatient. The benefit will be exactly the same. And putting all this data together, this is one of our publications in JACC Intervention, where we've looked at all the randomized controlled trial data. You can see that there's no difference in mortality, but certainly there is a significant reduction in reinfarction by doing complete revascularization. So very much the standard of care should be complete revascularization. But should we do all patients complete revascularization? And my answer is no. We have to take into account that many patients that were high risk were not included into the trial. And so we have to think about things like, whether the patients frail or elderly, whether they've got severe renal dysfunction, you know, whether it's a CTO, whether the patient has life-limiting disease. And the other things that we need to consider is whether we do it as an inpatient or post-discharge. And again, the sorts of things that you need to think about are the complexity of the non-culprit lesion, how good your result was for the primary PCI. If you get less than TIMI-3 flow, then, you know, I would probably say don't do it at the same time, do it post-discharge. How much contrast do you use? How complex the other lesion's going to be? So again, you know, lots of considerations. And the other considerations are about the patients themselves. So in the very elderly and frail, we know that there's a big risk of doing PCIs. This is some of our data where we published in 6 million patients undergoing PCI. You can see that in frail patients undergoing PCI, 1 in 4 of these patients developed an in-hospital bleed. 1 in 3 patients developed a stroke. 1 in 6 patients died. And so in a very frail patient, I would say that the best management is treat the primary PCI, but then medically manage non-infarct related disease. In cancer patients, again, you know, this is a paper that we published, again, in 7 million patients, of which 10% had cancer. You can see that the outcomes for cancer, particularly colon cancer and lung cancer, particularly with metastases, very high rates of in-hospital mortality rate, and 1 in 5 of these patients will have a major bleeding complication. So again, you know, these are the factors that you have to take into account when thinking whether you're going to do infarct-related artery PCI or not. We also have to think about whether we just look at the severity of the lesion by visualization, or whether we have other tools to assess severity. And one of these tools is intravascular imaging. And the last couple of slides, I'm going to show you some data how intravascular imaging may be useful, particularly thin-capped fibroatheroma. And in the Complete trial, there was an OCT sub-study. And what this showed was that in obstructive lesions, defined as those with a stenosis over 70%, about 1 in 3 of these lesions had a thin-capped fibroatheroma, which we know is very high risk for future cardiovascular events. And in the non-obstructive lesions, between 50 and 70%, around 20% of these patients had a thin-capped fibroatheroma. But we can further refine the risk stratification by data from the Prospect study. And what we see is that certainly patients with thin-capped fibroatheromas have something like a 4-fold increase in risk of events, so close to 5% rate of MACE at 3 years. But then if we then go to thin-capped fibroatheroma with an MLA of less than 4 millimeters squared, it goes to 10%. If we go then to plaque burden greater than 17%, 70%, 16%, and then thin-capped fibroadenoma with plaque burden greater than 70% and an MLA of less than 4, you have rates of close to 20%. And so to my mind, you know, this is very important information, because don't forget, in the Prospect study, most of the non-culprit lesions responsible for follow-up events were angiographically mild at baseline. So even with Complete, we wouldn't even treat these patients. You know, if it's a mild lesion, Complete says leave it alone. It's only the severe lesions that we stent. And so I think the Prospect study and other studies that are happening at the moment are making us rethink about our strategy, not just thinking about how significant the lesion looks on angiographic criteria or FFR criteria, but thinking about the characteristics of the lesion, whether it has a thin-capped fibroadenoma, the plaque burden, the MLA, and deciding our revascularization based on that, because 1 in 5 patients with thin-capped fibroadenoma with significant plaque burden and MLA less than or equal to 4 millimeters squared will have an event at 3 years. What we don't know is whether stenting these lesions that may not look too severe from the angiographic perspective, whether it will impact on outcomes. And certainly there's going to be some data presented at TCT that may answer that question. So I think, in summary, to finish off, Mr. Chairman, 50% of Stemi patients have multivessel disease. treating multivessel disease in the largest randomized controlled trial, the Complete Trial, is associated with a reduction in the risk of future AMI as well as ischemia-driven revascularization. Should we be treating all patients with multivessel disease? Should we be tackling all their lesions? Of course not. We need to consider the characteristics of the patients, whether they're frail, whether they're very elderly, whether they have cancer or other life-limiting conditions. In those sorts of patients, manage medically. We also need to consider when we do the treatment. You know, should we do it as an inpatient or post-discharge within 40 days? And again, in your decision-making process, you need to think about the complexity of the non-infarct-related lesion. You need to think about how good your result is, how complex it's going to be, and so forth, before deciding how much contrast you've given, before deciding whether you're going to do this as an inpatient or an outpatient. In my view, there's a number of outstanding questions. I think first and foremost, how do we identify lesions that are high risk, that have event rates of up to 20% at 3 years, that didn't enter the trial, i.e. those that look angiographically not very severe, but when you IVUS them, they have a thin cap fibroatherioma, heavy plaque burden, MLA less than 4%, 4 millimeters squared. What do we do about CTOs? I mean, only 1%, 2% in the Complete Trial were CTOs. So, should we treat them, leave them alone? My practice is to leave them alone. And what is the role of functional significance? Remember that the Complete Trial included patients either with intermediate lesions that were FFR positive or just severe lesions on angiographic criteria. There hasn't really been good data to say what happens if you compare multivessel PCI with FFR versus without FFR, if there's a difference in outcomes. So thank you for your attention and look forward to the discussion.
Thank you, Professor Mamas, for this great presentation. I hope now my panelist, Dr. Mohammed Mukhaini, he's a senior consultant interventionist in the National Heart Center and the Royal Hospital Oman, and Dr. Abdallah Al-Anizi, intervention cardiologist and the director at the Chest Diseases Hospital in Kuwait, to join me for the discussion. I will start with the question regarding the patients who comes in with multivessel disease and cardiogenic shock. This always comes to us regarding how to intervene in such cases and which vessel, especially if you face a CTO in such case. How is the approach in such cases would be?
Well, I mean, to my mind, we have data from the Culprit shock trial. And so certainly, in contrast to what I've been saying, it's very much a target lesion only approach in shock patients. So you should not be aiming to do multivessel PCI in these patients. You do more harm than good. Sometimes though, as we're all aware, in cardiogenic shock, it's very difficult to know which is the culprit lesion, and that becomes a challenge then.
It is a challenge. It is a challenge. I would ask the audience or the participants, they can write the questions in the question section and they can send it, and we will come to this later on, hopefully at the end of the presentation after we present our cases. So Dr. Abdullah and Dr. Mohammed, if you have any question, please.
It's actually a comment. Actually, I really agree with you, Professor Mamas. Yeah, many factors play a role when you are doing a primary PTCA for a patient. And how simple is the lesion, how simple and how long we can take to open it. Plus, if there is any other cofactors like the renal functions, the hemodynamic status of the patient, the difficulty of the lesion, all of these, they really play a role. I mean, a lesion should take 1 hour to open it. Maybe you will back off and just bring the patient again for the other vessels. And if it is a simple lesion, you will do it in the same setting. So I totally agree with you.
Yes, I mean, I think our practice has changed recently, particularly during COVID, and I don't know, what the experiences of the other panelists are. When the Complete Trial came out, I would generally do the index PCI, send them back, and then bring them within a month and do the non-culprit lesion. Nowadays, I tend to do it in the hospital whilst they're in, because I don't want to bring the patient back and risk having them catch COVID, and particularly in the United Kingdom during the COVID period, our elective activity has dropped by 90%. And so it's very difficult to get these patients back in time to do the non-culprit lesions. And so generally, during COVID, we've changed our practice and just do everything in the in-hospital setting. I don't know what other panelists do.
This is actually what we do. It's just, if it is a simple lesion, just we'll go for the other vessels. But if it takes a lot of time, then just we send them back and bring them within 2 weeks to do the other vessel. That's what we do now.
I tend myself to complete revascularization during the same admission. Very rarely we discharge the patients before we do complete revascularization. That's what is my current practice now. Unless it is a complex CTO or the patient has other comorbidity like renal impairment, we would try our best to complete revascularization during the same hospitalization.
Would that be CTOs as well, or do you leave CTOs?
Yeah, if CTO, it can be done definitely before discharge, but I mean, if there's some comorbidity, like a patient has renal impairment, we prefer to give the patient more chance, to recover, especially if the creatinine is quite high. If the patient has some other problems like the uncontrolled diabetes, we give time to better control diabetes and so on. We optimize the patient condition before we complete the revascularization. If this can be done before the patient discharged, then we do it. If not, then we postpone it. But most of the time, I would say 90% or 95% of the time, we complete the revascularization during the same admission.
And how many, just a question to the panelists and to the speakers, how many of you use imaging, coronary imaging for the non-culprit lesion during the primary PTCA?
So my practice is slightly strange. Well, not strange, I'd say, I'm sort of on the extreme. 100% of my PCI is OCT guided. So every single PCI that I do, I will do an OCT before and after, because I think it gives you very important information. If you ask me, do I revascularize angiographically non-significant lesions within cap fibroathyroma? No, there's no data for that. We know that they're at increased risk, but we don't know whether revascularizing those has benefits. So I'll only revascularize those lesions that appear to be anatomically significant.
Well, first, thank you, Prof. Mamas, an excellent review of the literature regarding this topic. To answer Dr. Mohammed's question regarding intracoronary imaging, personally, I use high percentage of imaging during my procedure, around 70%. I tend to use IVES more often than OCT because I like the idea that I don't use contrast and I can use it in osteal lesions and large vessels like left main, as you know, the limitations of OCT in these situations. And many times OCT show you things you don't want to see and you don't want to intervene based on, small findings that you might find on OCT, as Prof. Mama is probably more experienced in interpreting this. Just to Dr. Khalid's comment about shock patients presenting with Stemi, I think our practice has shifted based on the shock Culprit Trial. Personally, over the last few months, we've created our shock protocol in my center, and we tend to use mechanical support early on in these patients, especially in patients on high doses of pressors. And personally, I usually put them in mechanical support. Our go-to device is usually Impella CP, unless the patient arrests, in which case we put VA ECMO before opening the culprit vessel, and we rarely do the non-culprit vessels. With regards to the non-culprit vessels, to Dr. Mohammed Khomeini questions, I rarely do imaging in the index procedure. I think learning from Prof. Mama's presentation, there's so many factors that goes into the decision making for intervening or not intervening in non-culprit vessel, it's really difficult to make that decision when you're dealing with a primary PCI. So I think if you're dealing with a primary PCI, you do your primary PCI, you get the patient out of the acute situation, and then the next day you think about the situation, whether this patient will actually benefit from revascularization of the non-culprit vessel, and then you make a decision, a thoughtful decision at that point.
I think in primary PCI, using imaging is very important. But in our center, we don't use in 100% of cases, just only in selected cases. And the second point, as regard to CTO in the setting of primary PCI, I think it is better to give chance for building up collaterals for this CTO. Because in most cases of CTO and the other culprit, most cases doesn't have good collaterals. And I have a lot of cases when I give a chance, weeks, not just only in the same admission index, the collaterals build up very well, and we can do CTO after 3 weeks or 1 month, like that.
Okay. Thank you, everybody. I think we should move to the cases and our other presenters. I would like to welcome Dr. Fikri Adib and Dr. Ahmed Qasim. For the first case for tonight, we're going to have a coronary intervention for anomalous left coronary in the setting of acute coronary syndrome. Our speaker is Dr. Fikri Adib. Professor Fikri Adib. He's a senior consultant interventional cardiologist in Zuleika Hospital in UAE. So I would like to welcome him to the presentation, and if he can start the case.
Thank you very much for your kind introduction. It's my pleasure to share with you an interesting case tonight. A case of anomalous left coronary artery in a setting of acute coronary syndrome. This was a 55 years old gentleman, a local, who presented to our emergency room with infralateral myocardial infarction, ST elevation myocardial infarction with pulmonary congestion and eventually pulmonary edema. His comorbidities include type 2 diabetes, hypertension, and dyslipidemia. He was taken immediately to the cath lab as usual, and I tried to visualize the left system, but you can see I could not find the left coronary artery from its usual position. So because of the patient condition, I did not spend much time here, and I went to the right coronary artery, which as expected was totally occluded with quite big clot burden. We used the aspiration catheter here, withdraw some clots from the coronary artery, and then you can see the flow improved significantly after in aspiration. However, there was significant residual lesion, which was dilated with a balloon, and then eventually a stent was deployed, and this is the final result. So as a simple, straightforward procedure, I had the time to look for the left coronary after securing the TME3 flow in the right coronary artery. And as we will see in the next slide, the left main coronary artery was arising from a separate ostium near the origin of the right coronary artery from the right sinus of valsalva, turning all the way from the right to left side of the heart, bifurcating into the LAD and the LCX. Here we are. You can see here the left main coronary artery, quite a long one, and it's coming from a separate ostium near the origin of the right coronary artery, going to the left side and bifurcating into the LAD and to the circumflex artery. If you might look carefully here, you might appreciate that the left main coronary artery is tapering. There's some distal lesion in the left main extending into the LAD, and there was significant proximal to mid-segment lesion in the circumflex artery. You can see this in different views here. So the question here, what to do? And we had 2 options given to the patient. Of course, bypass surgery was offered because of the complexity of the lesion. And however, the patient was not happy for that, as most of our patients do. So we, proposed to do PCI, provided that the left main coronary artery course is benign. The patient, opted for the second choice, and after the patient was sent to the ICU and stabilized, and he was in better general condition, we sent the patient for CT angio to visualize the course of this left main in relationship to the surrounding structure, particularly the aorta and the pulmonary trunk. And these are the images from the CT angio. You can see here, this is the origin of the right coronary artery, which is quite open, and you can see the stent here in situ, and you can see the origin of the left main coming from a separate ostium near the right coronary artery, going retro-aortic and posterior to the aorta here. And you can see this is the left main pulmonary artery, which is usually anterior to the aorta. This picture shows that more accurate and more clear. You can see here the left main coronary artery, quite long one, going retro-aortic to the left side of the heart. And you can appreciate the narrowing in the distal left main here, extending into the circ and the ostium of the LAD. So the patient was taken back, I think it was like 4 or 5 days after the infractated artery was opened, and we did IVUS prior to the intervention for proper assessment of the entire length of the vessel and diameter measurements and optimizing the stent. We always, we were discussing, whether we do IVUS for the non-infractated artery. I always do it in the case of left main stem. Any left main stem, I have to do it with IVUS for the purpose of measuring the right diameter of the artery and optimizing the result after stenting. The procedure was a bit challenging, as you might expect, because of the anomalous anatomy, but it was feasible. Here we can see the IVUS pre-dilatation, and we are withdrawing the IVUS probe from the LAD back to the ostium of the LAD and the left main, and you can see the starting of the plaque here in the proximal LAD. And as we go back into the left main, you can appreciate the plaque burden, and it was significant narrowing in the ostium of the left main. You can see that here, it's coming soon. So this is the ostium of the circ, and you can see the narrowing in the left main, distal left main artery. So that was confirmed by IVUS, and we had the information that we needed to collect before the intervention. So we put 2 wires, one in the LAD and one in the circ. And this is just showing the IVUS, so when it was done in the LAD back to the left main. And we did ballooning of the left main, distal left main proximal LAD. And then eventually a stent was positioned and was deployed. And after that, we opened the struts in the stent through the left circumflex artery. And then we prepared the lesion in the circumflex artery by balloon dilatation. And then I put a long stent covering the whole lesion in the mid to back to the proximal and ostial left circumflex artery, with the stent coming a bit inside the left main. And then I did a mini crush, for the stent in the circ. I'm not showing all the pictures for the sake of time. And then, as we always do, we finalize by kissing balloon technique. And then you can see that this is the result after kissing balloon. The artery looks fine. It's acceptable result. And as usual, we do IVUS post. And you can see here, we are coming from the LAD distal to the stent backward. You can see the stent well opposed against the intima in the coronary artery in the LAD backward to the left main. I did not show you the pot. We did pot, of course, for the left main, and we optimized the stent in the LAD and circ, and this is the final result, after pot, which I think it looks quite satisfactory. So the patient was discharged the next day. So we kept the patient in the hospital for these procedures, and we usually complete the revascularization 1 day before the planned the day of discharge. And patient was discharged, after that, and we have been following the patient now for about 6 months, and he's doing fine. Just a quick review about anomalous coronary arteries. The incidence is quite low, 0.78 to 1.3% in all invasive angiographic studies. In CT angiographic series, the incidence is a little bit higher, 0.99 to 5.8%, because of the higher sensitivity for coronary CT angio. The majority of these cases had no clinical consequences, and there was no need to do any intervention. However, some of these anomalies can intermittently or chronically impede myocardial perfusion, leading to clinical manifestation such as angina, myocardial infarction, congestive heart failure, ventricular aneurysm, or sudden cardiac death. In a national registry by the US of competitive athletes, which was done between 1980 and 2006, anomalous coronary arteries were found to be the second most cause of sudden cardiac death, 17%, after Hookham, 36%. The types of anomalous coronary arteries were classified into 4 groups. Either anomalous origin of the coronary artery from the opposite sinus with interarterial course, like our case, or coronary arterial origin from the pulmonary artery, or coronary arterial fistula, or congenital atresia of the left main coronary artery. The usual diagnostic tools are echo, CT angio, MR imaging, of course, coronary angiography. When we look at the anomalous origin of coronary artery from opposite sinus of Valsalva, the incidence is even lower, 0.15 to 0.39%. by coronary angiography, and a little bit higher by CT, 0.35 to 2.1%. And these have 4 different types. Either they are interarterial between the aorta and pulmonary artery, or transseptal, subpulmonic, or prepulmonic, or retroaortic, like the case I just showed to you. This is the course of the interarterial, where the left main runs between the aorta and the pulmonary artery. This is an example of the interarterial, and we can see how it looks here by CT angio. You can see also in this CT angio how the left main coronary artery is coming from the right side of the valva and is running between the aorta and pulmonary artery. This is the case I just showed you. It is coming retroaortic, so it is the 4th type of this classification. So in conclusion, anomalous origin coronary artery are rare. Non-invasive techniques are usually sufficient for the diagnosis. They are usually diagnosed accidentally during a routine cardiac assessment, like in our case. The majority do not need intervention, and conservative treatment is sufficient. If the patient had anomalous coronary artery from the opposite sinus of a valva, and it is this type, one of these 3 types, interarterial or transseptal or prepulmonic, cardiac surgery here is a must. There is no option for intervention angioplasty in these 3 types. However, our patient was diagnosed during acute coronary syndrome, and he has definite atherosclerotic lesions for revascularization, and he was lucky enough that his left main coronary artery course was benign, and coronary intervention through PTCA and stenting was feasible and successful. And this is probably the only type of anomalous coronary artery that could be treated with means of intervention cardiology, intervention angioplasty and stenting. Thank you very much for your attention, and I would be glad to have any questions.
Thank you, Dr. Fikri, for this great case that represents the case of a Stemi with anomalous left main with another lesion, and the decision was taken to have the discussion and then take the patient after a few days for the intervention for the left main left circ stenosis. I would like to welcome also Dr. Ahmed Qasim. It's a pleasure to have him with us. He's a consultant intervention cardiologist in King Abdulaziz University Hospital in Jeddah, Kingdom of Saudi Arabia. So he's going to present another case for us, which is a rare representation for STEMI with the spontaneous reperfusion. So I would love to have him with us on board, and welcome Dr. Ahmed.
Dr. Fikri, please make stop sharing. Stop sharing.
I am trying to do that. Okay, let me see.
I think it's upper.
Okay.
Stop sharing.
There is the share slides to stop the share slides. Dr. Fikri.
Yeah, I'm trying. It's showing me new share. I don't know why.
No, it is in the upper part, I think.
Okay, I got it.
Okay.
Sorry for that. All right.
Go ahead, Dr. Ahmed.
Thank you, Dr. Khalid. Thank you, GIS committee. It's my pleasure to share my case. Rare STEMI presentation, spontaneous reperfusion with underlying Minoka. My patient is 53 years old, the male patient with known history of diabetes, hypertension, and history of heavy cigarette smoker for 40 years. He presented to our center after only 3 hours of chest pain onset. And ECG done showed sinus spasm with right bundle brush block and ST segment elevation in the inferior leads with ST depression in lead 1 and EVL. And of course, the guidelines recommend either left or right. We should go for urgent angiography. And our patient actually not only right bundle mesh flow, but also ST segment elevation, the inferior leads. So we take the patient from ER to the CAS lab for primary PCI. And this, his left system showed significant lesion in the proximal LAD. And this is the right system, surprisingly showing Stemi 3 flow and borderline lesion. Of course, we know that Stemi is most commonly presented with total occlusion, but our patient surprisingly presented with Stemi 3 flow and borderline lesion despite this segment elevation. So the question actually, which is the culprit lesion? Is it LAD, which is tight, or the borderline lesion in RCA? And the second question, which vessel to intervene? Is it the tight, to start with the tight lesion first, or with the borderline lesion? And what about the non-culprit in staging procedures? Of course, it is clear from the clinical presentation that our patient is inferior wall ST segment elevation from ECG and echocardiography showing inferior wall hypokinesia, infralateral wall, and infroseptal wall also. So it is a clear cut, it is inferior wall, and RCA is the culprit vessel. The data mentions that 55% in a setting of primary PCI had multivessel disease. And in this study, 15%, 20% underwent primary PCI only for the culprit, and 20% primary multivessel PCI, single stage, and 15% staged in the same admission. So the most common strategies for dealing with non-culprit lesion, either culprit only, then staging PCI of non-culprit during index hospitalization or sooner after discharge. And culprit only or optimal medical treatment, then management of the non-culprit based on stress-induced ischemia or spontaneous ischemia after that, are most commonly primary multivessel single stage, either guided with angio or FFR. But there is many important factors which affect our decision to go for single stage PCI or staging of the multivessel PCI during primary PCI. Clinical factor in the patient and procedural factor of the primary PCI, complexity of the procedures, duration, contrast, and final result. It is Stemi 1, Stemi 3, and lesion characteristics as well, complexity of the culprit lesion and non-culprit lesion as well, and also is there left mean and CTO or classification. All these are important factors. The American guidelines in 2013, it clearly showed it is a class 3 recommendation to do the non-culprit vessel during the primary PCI setting. And actually, it is recommended to be at separate time, either class 1 or class 2, based on the clinical status. But this, it is now canceled, and there is a new recommendation for this American guidelines to be done as a time of primary PCI or as a planned stage procedure after that, based on the advancement of the technology and recent trial. And also European guidelines recommend clear now that in patient with primary PCI and multivessel, we can do the non-culprit as index procedures or before hospital discharge. It is a class 2A recommendation. And this based on many trials. I don't repeat, Dr. Mamas mentioned all this in detail, just highlighting. So in this Prami trial showing 65 reduction in this non-fatal MI, refractory angina with preventive complete revascularization. And also the same for Culprit trial showing complete revascularization appears beneficial at reducing major adverse cardiac events. And same for the compare acute trials, which using the FFR in the setting of primary PCI in the same procedural index in comparison to the Dynamic 3 pre-multi trials, which using the FFR in staging procedures. And those studies showed that FFR guided PCI decreased acute and repeat revascularization rates, though don't impact on the mortality or reinfarction rates. And also finally, the large trial, complete trial, which showed that complete revascularization superior to culprit-only revascularization. But the question, when single stage multivessel PCI is recommended? I think when the culprit has been done, treated successfully in short time, And also when non-culprit is a critical proximal lesion with a large area of myocardium at risk and cannot wait for second stage. And also non-culprit lesion with feature predict simple BCI procedures within 15 or 20 minutes and using of small amount of contrast additionally. But most importantly, clear-cut indication with almost no doubt if there is two lesion with two thrombus containing lesion. So in this case, you should go for a single stage multivessel BCI. And this pros and cons for using of single stage BCI ensure complete and early revascularization, prevention of recurrent ischemia and infarction, stabilization of additional disrupted plaques, improve LV function, survival, reduction of hospital stay and cost, decrease risk of access site vascular complication, lowers the need for repeat procedures in the future. But also the cons for single stage is prolonged procedural time, potentially increased procedural risk, large contrast volume, and risk of jeopardizing remote viable myocardium due to distal embolization, flow, side branch occlusion, loss of collaterals, and also high rate of late TVR and MACE, and increased radiation exposure, and in some cases, unnecessary revascularization due to overwhelming spasm due to inaccurate assessment of the lesion. So back to our patient, actually, decision to go for RCA, which is a borderline lesion and a small lesion, actually, despite the LAD is tight. But by ECG criteria and echo criteria, this is the culprit lesion, actually. So, second most important question, why this Stemi case with a clear ST segment elevation and only chest pain, 3 hours duration, presented with TIMIS 3 flow and not total occlusion? Of course, it is most commonly due to the spontaneous reperfusion. And this is a very important data by the Dewald et al., which highlighting very important data that within the first few hours of STEMI presentation, the total occlusion percentage is 90 to 95%. But with passing of time and activation of the intrinsic fibrinolytic system, there is reduction of the percentage of total occlusion artery of STEMI on presentation, reaching up to 50 to 65% of cases. And the proposed pathophysiological of spontaneous reperfusion, like our patient, which is actually borderline lesion, but vulnerable plaque. And of course, with vulnerable plaque, rupture of this plaque can causing after that occlusion of this artery with a thrombus. But with activation of the endogenous thrombolytic system, and of course, it is dynamic process ranging from occlusion, de-occlusion, and eventually spontaneous thrombolysis and spontaneous distal embolization and opening of this artery. So we can find cases with TIMIS flow, despite it is initial event is total occlusion and it is ST segment elevation MI. And the fourth universal definition of type 1 MI, of course, all of us know that the most common cause is the plaque rupture and erosion with occlusion of the artery, and this is the most common presentation. But in non-occlusion of the artery, we know that the traditional is the non-ST segment elevation MI. But in some cases, there is non-occlusion, but with ST segment elevation MI, like our patient. There is, despite ST segment elevation, it is non-occlusive and TIMIS reflow, and this is what we call it MINOCA. And of course, MINOCA, according to the data published, and this proved by our case, that ST segment elevation usually is not too much elevated, just only minimal elevation. And also, the cardiac enzyme is not only extensively raised, it is only minimally raised, like our patient. The first set was only 1.3, and second set only in the second day 58 only. And spontaneous reperfusion is proved by many studies that by ECG 14% and geographically 14.7% also in this study. And of course, another study showing that spontaneous reperfusion documented in 22% of cases. And recently, the European guidelines put a very important statement that failure to identify the underlying cause in MINOCA patient may result in inadequate and inappropriate treatment of such a group of patients. So MINOCA is a workup diagnosis, like heart failure. We should doing workup to know what is the underlying pathogenesis. So the important question in our case, what is the underlying mechanism of myocardial damage in this patient presented with ST segment elevation and raised troponin and TIMI free flow and just only borderline lesion. So this, of course, this spontaneous reperfusion need number one, thorough review of the angiogram to rule out any missed lesion. Actually, maybe in another orthogonal view, it is significant, and so should thoroughly review the angiogram. But if the angiogram showing clear cut, no stenosis at all, it is 0%, so it is non-coronary causes. And most commonly cardiac causes like myocarditis, Takotsubo, or other cardiomyopaths, or extra cardiac causes like aortic syndrome, pulmonary embolism, renal impairment, type 2 MI, stroke, sepsis, and the most importantly, if there is borderline lesion, up to, according to the guidelines, up to 50%. So we should review any missed obstructive lesion, plaque disruption, coronary spasm, coronary dissection, SCAD, spontaneous coronary embolism, coronary microvascular dysfunction, and this all under the titles of MINOCA. But the question, is it good to do FFR or OCT in the acute setting for the culprit vessel itself? I think OCT is the best choice for the culprit lesion in the acute coronary syndrome. So this is what I did actually. I doing OCT for this patient showing there is a clear-cut high plaque burden and lipid-rich plaque with cavity and rupture, and this white thrombus in the middle here in this artery. And this showing also there is very large plaque burden with borderline lumen, which is reflecting the positive vessel remodeling in such a group of patient. And of course, the ruptured plaque is clear by OCT here with the thin cap fibroaceroma also is clear. And this ruptured plaque, of course, evacuated the necrotic core and become revascularized after activation of the intrinsic thrombolytic system. So this very important study showed that the most common underlying mechanism of acute coronary syndrome is a plaque rupture, plaque erosion, calcified nodules, but most importantly, this vulnerable plaque criteria, which is lipid-rich plaque, thin cap fibroadenoma, less than 65 micron, and microchannel, like our patient in this case. So I decided to went for stenting of this lesion, actually 35 by 30, 20 atmospheric pressure. Then this is after deployment of the stent. But after deployment of the stent, is it done again showing malapposition of this stent. So another large NEC balloon 4 by 15 at 20 atmospheric pressure used many times to ensuring the well apposition, and this is the final OCT showing just only plaque prolapse or thrombus prolapse inside the lumen, but well opposing of the stent to the wall. So second most important assessment for suspected cases of MINOCA is using LV angiography, or we can use also echocardiography either before or after BCI to ensure there is epicardial pattern or microvascular pattern. Epicardial pattern, which is only restricted to the single epicardial artery territory, while the microvascular pattern, it is beyond, extended beyond single epicardial coronary artery territory, like our patient. Echo done for this patient showing that it is mainly epicardial pattern and restricted to the RCA territories as it is seen clear here on the echocardiography short axis and parasternal long axis. And this also again in this apical 3-chamber view and 4-chamber view showing this epicardial pattern clear. So after 3 days from the primary BCI for this patient, I bring him back for the, he was still in the hospital, so I'm doing the primary BCI in 22 of April 2019, and after only 3 days, I take him to the cath lab again for the LAD. And of course, balloon dilatation first, then stent deployment for this proximal LAD, and 3 by 15. And this is the final after deployment of the stent in the LAD. So my take-home message, multivessel coronary artery disease in the setting of primary BCI is a common finding. And the recent data have shown potential benefit of complete revascularization, either single stage or 2-stage in the setting of primary BCI for a STEMI patient, which have led to guideline updates, as all of us know. And decision of non-culprit PCI should be individualized based on patient clinical status and lesion characteristics and area of myocardium at risk. And non-significant or borderline lesion with Stemi flow in the setting of acute coronary syndrome with ST segment elevation should raise the clinical suspicion for MINOCA, especially coronary causes due to spontaneous dissolution of the thrombus. As MINOCA is a workup diagnosis, so the investigation should be started immediately in the cath lab while the patient in the cath lab in the table by thorough review the angiogram to rule out any missed obstructive lesion or using intracoronary OCT to identify the plaque vulnerability like rupture plaque or erosion. And OCT is a gold standard initial tool in MINOCA, especially when there is non-significant lesion to identify accurately the underlying pathogenesis of acute coronary syndrome, especially vulnerable plaque characteristics, rupture plaque, synca, fibroaceroma, erosion, calcium nodules, red thrombus versus white thrombus. Thank you very much.
Thank you, Dr. Ahmed, for this case, great case, and congratulations for the great management. I think we should start the discussion part. I would ask my panelists to join me here. I would have a few questions from the audience, so and I will give them time also to send some questions. I think I have two questions from one of the attendees. He's asking regarding the reliability of the FFR in ACS setting, and I think the same attendee also asked about the what is the best modality to assess the significance of the other lesion during the index cath. Dr. Mamas.
So, I mean, I answered this privately, but personally, particularly in a left-sided culprit lesion, I don't think that FFR is terribly reliable at the setting of the primary PCI. But let's not forget that the largest trial to look at the question of complete versus target lesion only revascularization used angiographic criteria for the vast majority of cases. So anyone with a stenosis of greater than 70% had a PCI in the complete revascularization arm. It was only between the 50 and 70% that a positive FFR was mandated. And often the patients could have been randomized up to 2 days after the index procedure in this trial. And so there was no mandate really to undertake the FFR at the time of the index procedure. And let's not forget, in one of the studies I showed you, a 0.2% complication rate from the pressure wire. So in that study, there was 1 death and 1 STEMI. So doing pressure wires is not without risk. So personally, I think following what is the main evidence, I would go for angiographic guided severity, which is what the complete trial showed. To my mind, though, the bigger question is whether we're revascularizing a lot of lesions that don't need to be vascularized. And that's why I think the imaging of non-culprit lesion, particularly looking at the plaque characteristics, is so interesting.
I see. Another question is regarding the use of support hemodynamic devices like the Umbrella. I guess this always comes to the mind in the case of cardiogenic shock. So I think you also answered this privately, but why not? I mean, for the whole audience, they can, get an insight about it.
Yes. So, I mean, the practice in the United Kingdom is very different from perhaps North America. We don't use impellers. Impellers in North America are very industry driven, and certainly there is a financial benefit to hospitals to use impellers, and that's why often when you go to these meetings you see impeller being used for cases that frankly it shouldn't be used in. The question as to whether there is a benefit in the sort of case that you've discussed, I mean the trial data, when you look at it closely and look beyond the headline news, suggests that the benefit isn't that much greater than a balloon pump. So I generally don't use impeller in my practice.
I see. Dr. Abdullah?
If you allow me, Dr. Khalid, I feel compelled to make a comment since I was the one suggesting the use of impeller. I mean, by and large, we shouldn't use anything routinely unless there is evidence to use it routinely. And for me, personally, I have no doubt that impeller has hemodynamic effects when we use it in certain patients. But it's not without complications. It's a very expensive device. In the Northern America, I agree with Prof. Mamas. There's maybe some financial influence. We don't have the same financial influence in Kuwait, but for us, we use it in patients that we think that will likely benefit from it. The problem is that the randomized control trials evidence is lacking in this arena because it's a very difficult cohort of patient to study. But from my personal experience, patients presenting with Stemi and cardiogenic shock who are not responding quickly to fluids and small doses of pressors, many of these patients, I find in my personal practice, they benefit from mechanical support. But it's a device that uses a large bore access. It doesn't come without complications. So it has to be done with someone with expertise in large bore access. So to summarize, the strong evidence is not there. There's some evidence from US PELA's registries, and there's some small retrospective studies. So I think it has to be used with caution in highly selected patients. And from my personal experience, it can be helpful in certain cases.
Dr. Muhammad?
I have just a comment for Dr. Deep. It's really an interesting case. Sometimes, when you are doing the angiogram and you think the left main is anomalous, you can do an LV angiogram and see an REO projection or aortogram. If you see a dot just posterior to the root, you know this is a retroaortic course and this is benign and you can go ahead. If you see septal branches coming from the left main, this is a septal course and this is benign. If you see what they call it an I sign anteriorly, this is anterior course and this is benign. If you see a dot sign just anteriorly compared to the posterior dot, so this is an interarterial course and this is a malignant course. So in the cath lab, before using the CT, you can get a hint where is the course of the left main. But really very interesting case, and I really congratulate you for doing it. Yeah.
Thank you so much. Of course, I do agree with you, but I still would do CT angiogram for the purpose of documentation.
No, I know, but I mean, if you are in the cath lab and you want to decide.
I knew before I do the CT angio that it is retroaortic, so it was not that difficult to know.
Because I've seen a patient 1 month ago, and she was just said just to take rest all the time and nothing. So I saw the angiogram. There were septal courses from the left main. I told her this is a benign course and you can lead your life normally. There is nothing else.
And I think in the setting of primary,
the patient also is not quite stable in the first in the index or culprit artery PTCA. Was having a lot of chest pain. He was hemodynamic unstable. So I just wanted to take him out of this and give him time, and then this can be done later on.
Sure. Very good.
Dr. Ahmed?
Yes. As regard to acute Stemi with cardiogenic shock, I think it is very important to revascularize as much as you can very fast. Opening of the artery is very important. Of course, using of Impella in our region, I think is limited in some centers. In our center, don't have Impella yet. We're using intra-aortic balloon, but our target initially to open the artery. In the meanwhile, we tell the team to prepare the intra-aortic balloon to be ready once we are open. So our target opens the artery. This is very important in shock state with the Stemi.
I think intra-aortic balloon pump and Impella are sometimes one would say that they were life-saving for some patients.
Of course. I mean,
with cardiac shock, with low blood pressure, many of these patients were saved by just having this.
Yeah, I believe in yes, I agree with you totally, and I believe in aortic balloon. I saved many patients with aortic balloon, but what I mean is that we don't delay opening the artery until the team ready with intra-aortic balloon. We should go for opening the artery. In the meanwhile, they are preparing intra-aortic balloon to be ready after that.
No, I mean, the IABP shock trial was negative, so there is no data to suggest that using a balloon pump in such cases has any impact on outcomes. So I would say that, it may be useful for the odd case, but again, there is absolutely no data. And in fact, the randomized trial data with big randomized trials has been negative for the use of balloon pumps routinely in shock cases.
I know that these are the result of the studies, but if I go with back some years when before the Impella, we were using the balloon pump, routinely in cardiac shock, and at least we feel that it helped us in salvaging many cases. When this was done in a study, it was not the case, but again, whether there is some financial interest here, or I don't know. We practically speaking, we used it, frequently in the past, and we managed to get a lot of patients with cardiac shock, very low blood pressure, out of this cardiac shock, and they survived. So I can say that it has no role. It still has a role, especially if it's the only thing you have in your cath lab.
I think also study coming from Germany, comparing the high volume centers using intra-aortic balloon to low volume center using intra-aortic balloon, and showing that this high volume center make great differences in the outcome. And this actually, I think, very important. If your team is expert and trained and can doing the intra-aortic balloon within short time in appropriate manner, it is make a great difference in the outcome, I think.
Abdullah, you were saying?
I was just saying that the problem with the cardiogenic shock, it's a very complex, it's a spectrum of disease, and this explains why the SCAI came up with the recent classification of the cardiogenic shock, because you do have cardiogenic shock and you have cardiogenic shock. So I think the biggest issue with the use of mechanical support in patients presenting with STEMI cardiogenic shock is knowing clinically which patients who will actually benefit. Because if you use a mechanical support in every patient, then your benefit will be diluted by the complications you will cause by inserting a large bore access. And I think the issue with balloon pump, I think the balloon pump study, the shock balloon pump study, there was 10% crossover in the study, and like that has an impact on the result of that study. So, and plus the balloon pump only gives you 0.5 liters of support. Whereas with the Impella CP, you can get up to 3.5. And now with the newer Smart Assist algorithms, you can get up to 4 liters of support. So I think there's a big difference of the amount of support you get from Impella compared to balloon pump. And I think the biggest, the holy grail for the mechanical support is patient selection.
Thanks everybody for this great discussion. I don't think I have any more questions from the audience. I think the take-home message here was clear from Professor Mammas regarding the individualization of the intervention and the cases. It is a very common finding during acute STEMI that you might find another lesion, a non-culprit, do the culprit one. Be cautious. The enemy of excellent is good. The good, the excellent. I mean, try as much as possible to do your part for the patient. The patient first comes in. Each case is different. Our patients are complex. They have other diseases, other comorbidities that might limit the intervention itself, the timing of the intervention, the amount of the contrast that we might use. All this come into an account when you think about doing the non-culprit. So I hope the message is clear, and I hope we have what do you call it, newer studies that might help us and give us an insight regarding doing the non-culprit lesions. Dr. Mamas?
Yes, I agree. I think, to my mind, you know, the way that I see the field developing in the next 5 years is moving away from just saying, oh, we'll just use FFR, or we'll just look at the severity of the lesion based on angiographic criteria, but using a much more considered approach where imaging will be key, and thinking about the characteristics of the lesion, and perhaps treating lesions irrespective of whether they're functionally significant or how severe they look on angio, but with high risk features that we know are associated with very high event rates at a number of years, because we know that cases where the lesion looks tight but they have, you know, calcified thick cap, their event rates are actually quite low. It's the lesions with thin cap, very heavy plaque burden, you know, MLA that's less than 4, those are the ones that have the really, really high event rates. And I really am looking forward to some of the data that's going to be shown in TCT, so the Prospect 2 trial, and particularly the Prospect Absorb trial, where there is going to be some outcome data presented there as well. I think that's going to be very informative, and I'm very excited.
All of us will be excited for this. Thank you, everybody. Been great and a pleasure, and have a good evening.
Thank you.
Good night.
Thank you, guys. Thank you.